Hey everyone, welcome to my Day in the Life series here on White Coats and Corgis. Most of you probably know me from Instagram or TikTok, where I make helpful free content for pre-meds and talk about my journey as a first-generation medical student. My mission here on YouTube is to give pre-med students all the information they need for a career in medicine. So in order to do that, I've teamed up with MedSchoolCoach to create this series where I'm going to do a deep dive on each medical specialty. And I want to start off by saying that it can be really difficult to accumulate the number of shadowing hours you really need to be accepted into medical school. And especially nowadays, this can be really challenging. A lot of physicians aren't open to shadowing opportunities in person the way that they were before. So that is why MedSchoolCoach decided to collaborate with over 20 doctors to give you a behind-the-scenes look at practically every specialty that you might be interested in. And this is all completely free. You can go to shadowing.medschoolcoach.com, register for the program, and then you get to choose whichever specialties you're interested in to shadow. At the end, you can fill out a short quiz, and then they'll give you a certificate of completion. That way you can count these hours on your medical school application.
All right, so my name's Hillary McCray. I'm a resident physician at the University of Utah, where I'm doing a 5-year training program in otolaryngology head and neck surgery. And so you might be asking yourself when you see the slide, what is otolaryngology head and neck surgery? And might not know much about that. So I'm going to kind of give you a brief preview of what I do on a day-to-day basis. So kind of when you look at what is on the national websites in terms of the American College of Surgeons. So otolaryngology is a type of surgical subspecialty, and you kind of look at how they define what our career is. And really kind of the emphasis of what I do on a day-to-day basis as a head and neck surgeon is I am trained to take care of the surgical and medical needs of patients that are presenting with various different types of head and neck pathologies. And kind of what that means in terms of what types of disorders and anatomy I'm dealing with is, so it could be anywhere from an ear infection that has gotten very complicated and is approaching the skull base, could be a respiratory infection that's causing acute stridor, or anything that's kind of causing obstruction in the nose and the upper airway. And really, we're dealing with some very complex anatomy and diseases in the head and neck, which is kind of the appeal for a lot of people that are interested in a career in head and neck. But really, how the American College of Surgeons defines what an otolaryngologist does is they basically said that we are understanding the basic medical science relevant to the head and neck, and how that can go on to affect your ability to hear, your ability to communicate with one another, and your chemical senses. And one of the things that really drew me to a career in ENT is that I deal with people's innate senses, whether that's their ability to smell, their ability to hear, their ability to see. All of those things we really are able to have a direct impact on our patients. And so, we're able to take our medical expertise of this very complex area and then offer complex surgical solutions to patients that have a variety of head and neck needs. And those can range from, doing a simple tympanoplasty for someone that has a hole in their eardrum, or if it's someone that has a very complex cancer that's invading, somewhere in their oral cavity, like their tongue, and then it has, disease that's spreading to their neck. We're able to really address all of those very complex needs for our patients. And so what does the training entail? So like any surgical subspecialty, that usually has a minimum of 5 years. So I'm in a 5-year training program. The first year, your intern year of residency, is spent usually doing 6 months of otolaryngology and then 6 months of training with either plastic surgery, neurosurgery, which we both, we work very closely with our neurosurgeons for a lot of different types of complex cases. General surgery, kind of learning how to take care of, post-operative needs among children and adults that are having different types of general surgery. Intensive care is also an innate part of your intern training. Usually we do about 2 to 3 months of intensive care. In terms of my training, I spent time in the burn unit, on a surgical shock trauma unit, and then in the neuro ICU as well. And then we also work with our anesthesiologist, because airway management is a pretty large part of what we do as otolaryngologists. We're kind of the airway emergency experts in addition to our anesthesia colleagues. And so really it's that relationship with other specialties that kind of allow you to build on the skills that you need to be successful as an intern. And then research is also an innate part of what we do as otolaryngologists. I think, anyone that's considering a career in ENT has some, interest in kind of expanding the medical knowledge about our field. And so usually there's some sort of research component built into your residency education. For me, I do about 6 months of research that's kind of spread out over the course of the 5 years, but there are some programs where you can do just a year of dedicated research, or even 2 years where you're under a special grant that allows you to kind of expand research opportunities on the national level. And then really the training, like we had kind of previously talked about, is a mix of operative experience and clinic time. And it's kind of, the ability to take care of patients in both of those capacities. It's very fulfilling. So what are the subspecialties of otolaryngology? So there are a lot of them, and you can go on after your 5 years of training to go ahead and do a fellowship. One of them, it could be rhinology or skull-based training. So any diseases that affect the sinuses, the nose, nasal obstruction, or even tumors that are going, in around the sinuses and kind of invading up near the skull base. And that's when we could kind of collaborate with our neurosurgery colleagues. You could go on to be a facial plastics and reconstructive surgeon, so addressing the various cosmetic needs of patients, anywhere in the head and neck. And also associated with that is the reconstruction. So either, with local flaps or free flaps, which I can kind of talk about a little bit later. Head and neck surgical oncology, which is my field of choice and what I will be applying to fellowship in. And really, you are a head and neck cancer surgeon, and you deal with patients that come in with a variety of head and neck cancer needs, or even endocrine needs in terms of thyroid, parathyroid care. And then also you're trained to be the reconstructive surgeon for those. And so sometimes that means that you're taking, someone's thigh and reconstructing their tongue, or, taking part of their forearm and reconstructing their tongue, and then doing the associated microvascular reconstruction for that. And really, it's a fascinating field, which is why I chose ENT in the first place, was because of head and neck surgery. Laryngology is addressing people's voice and airway surgery concerns. So people that have, difficulty breathing due to narrowing of their airway, or if they have, a particular injury to their recurrent laryngeal nerve that causes them to have a vocal fold paralysis. Being a laryngologist allows you to kind of, improve their quality of life related to voice and breathing. Neurology and otology is what you would consider an ear surgeon. So they're trained on kind of lateral skull base, and then any ear needs, including cochlear implants, which have a massive impact on the quality of life of other people that have, deafness or hearing concerns. And so really that, again, has a massive impact on people's quality of life. Pediatric otolaryngology, which I'm currently a resident on that service. So you're addressing basically all of the head and neck concerns among children. And so they're kind of like skilled in providing complex head and neck care to patients that have acute sinus concerns, or a neck infection, or even hearing concerns. And so they are able to take care of many different aspects of children with unique needs. And then sleep medicine and surgery is kind of a growing fellowship within our field. So you can offer surgical options for patients with really bad obstructive sleep apnea. And overall, most of these fellowships are 1 year. So most otolaryngologists that are fellowship trained will be done in about 6 years. Neurology is 2 years, and then some head and neck fellowships, some facial plastic fellowships could be 2 years as well. So what does my day look like? I round pretty early. I get up pretty early. I usually get up around 5 a.m., 5:30. I go in, I round. I'm currently the chief on the pediatric otolaryngology service. So I meet up with my other residents on my service. We see our patients. And then around 7 to 8, we talk to the attendings about their patients. And then we go to the operating room or the clinic. Usually, if I'm in the OR, I'm there pretty much all day dealing with add-on cases. I could also be in the clinic seeing patients for new consults or postoperative needs. And then we round again in the afternoon, go see how our patients are doing throughout the day. In terms of call, we are consultants. And so we get consulted by various medicine specialties or surgical specialties and the ER to come and see patients with a variety of head and neck needs. And so that's another aspect of being an otolaryngologist, is you're a consultant that goes sees, people that have, acute head and neck needs. So I'm just going to talk about a few cases that kind of give a variety of what we do as otolaryngologists and kind of what that means. So case number one is a 2-week-old infant that, say presented to the emergency room with several bouts of respiratory distress. On exam, they are found to have what's called biphasic stridor. So they have noisy breathing on inhalation and expiration. And then they're also found to have some retractions. The parents note that their symptoms are worse with agitation or feeding, that their breathing problems get worse with that. And then we do what's called a flexible laryngoscopy, where we take a little scope and we place it through the nose and it goes down to evaluate the voice box. And with that scope, we are able to find if there's any, problems or anatomy difficulty with the vocal folds. But really with that exam, there's no obvious source of stridor. And so given that there's no obvious source of stridor, we suggest that they go to the operating room for what's called a microlaryngoscopy bronchoscopy. And that allows us to kind of complete a full airway assessment. And then bronchoscopy is going past the vocal folds. And here you're showing, we're demonstrating a nice picture of what a bronchoscopy looks like. This is the trachea. On the left, this is our patient in this case. On the right, this is a normal trachea. A normal trachea looks like a U-shaped cartilage. The cartilage rings are kind of seen, more anteriorly. I don't know if you can see my pointer, but you can kind of see the nice cartilage rings. And then on the back, there's the membranous trachea, where there's basically there's not supposed to be any rings there. The only, part of the airway that should have a complete tracheal ring is the cricoid cartilage. That's the first cartilage in the airway. But this patient on the left is what we call complete tracheal rings. And they have abnormal O-shaped cartilage kind of throughout several segments of their airway. And that is an abnormal finding in a child. What do we do for that? So unfortunately, if this patient is having severe respiratory distress related to their condition, we would refer that patient for what's called a slide tracheoplasty, where we basically are able to do an airway reconstruction that is going to greatly increase the diameter of their airway. And so this is an aspect of pediatric otolaryngology that as an otolaryngologist, you would be able to address concerns as these. So children can have various causes for kind of respiratory distress. This one in particular is congenital. That means they're born with it. And usually they come in at a very young age, maybe even 2 days or so with, respiratory distress that is making it very hard for them to breathe. If this patient also had a very bad pneumonia, you could see looks like purulent or kind of infectious secretions, but those look like very normal secretions to me. Okay. So a slide tracheoplasty is something that we would do usually with our cardiothoracic colleagues. And it basically requires mobilizing some of the trachea, and you make several incisions, and basically you're widening the diameter of that airway. So by the end of the surgery, they go from a very tiny airway to something that's bigger where they can functionally breathe. It is a very complex surgery. This is a very rare condition that we don't see too much. There's other types of reconstructive surgery that we can do called a laryngotracheal reconstruction. And that's also for similar problems in patients where they have narrowing of the airway. And basically you go in and you excise those segments that are very small and stenotic and add maybe a piece of rib graft from the patient's rib to reconstruct that airway. And so, there's a variety of airway reconstructions, but this is kind of bread and butter of pediatric otolaryngology and is something that you could very well see if you were to come do a rotation with us. So this is a very interesting case. A 62-year-old comes in, they have a large nasal defect caused by a squamous cell carcinoma, which is a type of skin cancer, very common type of skin cancer. This was removed by the patient's dermatologist, and they present to your office as a facial plastic surgeon wishing to have some reconstruction and to restore that patient's prior appearance. So given the size and location of that defect, so you can see in this picture, it's involving a pretty large segment of this patient's nose, which is a very cosmetically sensitive area. That's somewhere where someone's looking at you all the time, and it would be a very obvious defect if it wasn't recreated or reconstructed appropriately. So, as a facial plastic surgeon or head and neck surgeon, you opt to perform what's called a paramedian forehead flap for reconstruction. This is one of my favorite procedures. You're taking someone that has a large defect on their nose that is very cosmetically unappealing, and you go to the OR and you do what's called a paramedian forehead flap. And you're basically taking the skin and the soft tissue and the associated vessel from someone's forehead, and you're able to rotate that down. And you can see in this second picture, they had taken this skin and soft tissue from the forehead. They closed that defect, and then they rotated that skin down to the patient's nose. You have to do this in a 2-stage procedure, meaning you're going to let the vasculature take to the nose, and then you go back later and you separate that flap now that it's kind of has its own vasculature. And you have to do that several weeks later after that flap has had the ability to take. And then this kind of long-term outcome, you can barely even notice this patient's defect. And basically you've restored their ability to kind of go out in the world and not be ashamed of their, prior skin cancer that they've had. And, most of these patients are, the initial reconstruction can be kind of quite scary for the patient. The long-term outcome is fantastic, and most patients do very well. And so this is just kind of one of the kind of local reconstructive options that we have for patients that have a variety of defects in their face or their neck. This is just one of the type of flaps we can do in this area. Patients can get defects on their cheek or their lip, and we have a variety of different types of local flaps that can help us recreate their natural appearance. So this will be a part of my career. More commonly, head and neck surgeons will see this, or facial plastic surgeons. Anyone that does kind of reconstructive surgery in the head and neck, you definitely could see this coming into your clinic. And, in very high, areas with high UV exposure like Utah, Arizona, Australia, you will be seeing a lot of skin cancer. And, we work closely with our dermatologists who create these defects to get rid of the cancer, but might need assistance with reconstruction. Number 3. So this is something that would commonly come into your head and neck cancer clinic. So 53-year-old female who's presenting with a left-sided neck mass. Kind of popped up a few weeks ago, no real infection that was associated with it, kind of just noticed it when she was touching her neck and that there was a lump there. Is endorsing a little bit of difficulty swallowing, has no history of smoking or drinking. And then you get what's called a PET CT, which is looking at glucose uptake within the tissues. And basically this arrow with the bright, lime green is kind of showing what we would be concerned for a metastatic lymph node. And so you might ask yourself, what is the cause of this patient's condition? So this patient is presenting with what we would call an unknown primary neck mass, meaning that they have a neck mass that is concerning for cancer, but we don't know where it's coming from. So this patient's presenting with a lymph node metastasis that is likely, in most circumstances, coming from the patient's oropharynx. You might ask, what in the heck is the oropharynx? Your oropharynx is basically your base of tongue all the way in the back of your mouth. And it also encompasses your tonsils, some of your soft palate, and it's basically all the way in the back of your mouth. And this is an area that is at very high risk for HPV and an HPV-related cancer. Now, you might be thinking to yourself, HPV, I thought that causes cervical cancer. It does. However, head and neck cancer related to HPV infection is on the rise. And this is something that otolaryngologists are seeing kind of at a very rapid rate. And so basically this HPV infection can harborize in the oropharynx and then go on to cause a cancer that involves the tonsil, the base of tongue, anywhere in the oropharynx. And it's the same type of tissue that it kind of likes to harborize in and cause, potentially a metastatic cancer. Now, the interesting thing about this is head and neck patients are typically thought to be patients that may have a smoking history, chewing tobacco, alcohol use, but these patients that have HPV-related cancer are not, found to have these standard risk factors for head and neck cancer. What we can do for this patient, we can go on to provide both surgical and non-surgical options. Surgery might entail taking a cuff of tissue around that head and neck cancer, sending it to pathology, and then also sometimes we would recommend doing a neck dissection, which means that we would go in and we would take the lymph nodes. This patient presented with a neck mass that was concerning for metastatic squamous cell carcinoma from the oropharynx. So we would probably recommend also going in and doing a neck dissection to take out the lymph nodes that could be involved from that cancer. The non-surgical options could include radiation, chemotherapy, and that could potentially cure the patient. Sometimes it's a combination of surgery and chemotherapy or radiation. It just depends on the severity of the cancer. And really, as a head and neck surgeon or a surgical oncologist that takes care of patients with head and neck cancer, otolaryngologists are able to follow these patients long term. We see them usually every 3 months during the first 2 years, and then every 6 months after that, to make sure that they have no recurrence of their disease. And really their point of contact for their head and neck cancer, in addition to their oncologist. And I would say it's a very fulfilling career, and I love what I do every day. Why should you consider a career in ENT? Basically, you can improve the quality of life and someone's life trajectory among patients that are facing a variety of different diseases that affect the head and neck. I think it's a really good mix of clinic and surgery. I think that, you're not purely in the OR, and you are also able to help patients in the clinic as well, with even just kind of like local procedures that can be done while the patient's awake. What I also like about it is I treat kids, I treat adults, I treat men, women, basically whoever has an acute head and neck need, they can come and see me. And so I don't, I'm not limited to just seeing, children. I can see basically anyone that presents to my door. I also think that otolaryngologists are really happy with their career, are very easygoing, even though, you could think of surgeons as being kind of like maybe a more of a rough crowd. I think otolaryngologists are really happy and they love to teach. And I think that that was another thing that really appealed to me, is that they are very, lovely people to be around. And then, there's the potential to go into a variety of subspecialties after otolaryngology. It kind of lists some of the options. Really, the anatomy of the head and neck and the pathology that we get to treat on a day-to-day basis is amazing and really fulfilling.